Hello, welcome everyone. So get you to the right slide here. So today we'll be reviewing the basics on MASLD. Again, my name is Emily Przybyl. I'm a PA from the Erie County Medical Center in Buffalo, New York. You can scan this QR code for attendance for the meeting. This is also some additional information, educational material regarding the GAP MASLD MASH community, and there's different information as well. So let's start with reviewing steatotic liver disease in general. There has been a change in the nomenclature. So we can kind of just review. So steatotic liver disease is our umbrella term. Over to the left, we kind of get into the MASLD and MASH, so metabolic dysfunction associated steatotic liver disease, and the more aggressive form being when it's associated with steatohepatitis or MASH. I like the new nomenclature because it's a little bit more descriptive. It incorporates the metabolic risk factors, but also incorporates when patients do drink, some level of alcohol. So it kind of breaks it down further into metabolic dysfunction, and then MASLD is like kind of in the middle, where they have the metabolic risk factors, but also drink some alcohol. And it kind of further breaks it down into, are they more predominant on the MASLD side or more predominant on the alcoholic liver disease side? It incorporates your weekly alcohol intake versus your alcohol daily intake. Some people may not drink every day, but their alcohol use is increased on the weekend. So it's nice to kind of have that differentiation there. And some perspective is that one alcoholic beverage is approximately 14 grams of alcohol. So it's a little bit of a tricky graph, but with that breakdown in mind, you can kind of see that, not that much alcohol can kind of put you into that, ALD predominant category. And then further to the right is alcohol-associated liver disease. There are some outliers where you can get some fatty liver or steatotic liver disease from DILI, so drug-induced liver injury, some monogenic diseases, which we'll get into a little bit more later in the presentation. And then cryptogenic is, we've ruled everything else out, and we don't know why there's fat in the liver. A little bit further into the MASLD. So we get the steatotic liver disease, and then we go down our little flow chart. Does a patient have metabolic criteria? So our criteria over on the right, we have adult and pediatric criteria. And you can kind of look through there with the BMI, their fasting glucose or diabetes, blood pressure. It also incorporates their triglycerides and HDL. Which you only need one of those 5 criteria. So honestly, thinking about the patients that you saw today, I feel like most of your patients are going to have at least one of those metabolic risk factors. So let me go back to our flow chart. If they do have at least one of those criteria, you're going to go to the left and you're going to say yes. From there, do they have any other causes of steatosis? Do they drink alcohol? You can kind of break that down into, is it just metabolic criteria? Or do you feel like they would fit into that MASLD overlap? If they do not have any metabolic risk factors, you're going to go over to the right. And then kind of think about, are there any other causes? Do they start a new medication? And we also want to rule anything else out. That's kind of why we do our broad chronic liver disease workup, to rule out those monogenic diseases. And again, if we've ruled everything else out, they don't have other risk factors, then we determine that it's cryptogenic disease. So how will this affect your practice? So the big thing is that the MASLD kind of replaces the NAFLD. MASH kind of replaces the NASH now. And just think that the MASLD and MASH is, again, a little bit more descriptive. And the big reason for that change is removing the stigmatizing language there. So we're getting rid of the alcoholic, we're getting rid of the fatty in the name to be more descriptive. And essentially they are interchangeable, but again, the new nomenclature is a little bit, in my opinion, just a better change. It still uses the natural history, the same biomarkers. So just an update on the names. So getting into those criteria a little bit more, you just need one out of these 5 cardiometabolic risk factors. Is their BMI greater or equal to 25? We also change it a little bit based on ethnicity. So our Asian population, that criteria is decreased to 23. Or do they have a enlarged waist circumference? Number 2, we're looking at their blood glucose. Is it impaired fasting glucose? Are they pre-diabetic, diabetic? On their blood pressure, is their blood pressure high or already on treatment for hypertension? The triglycerides, is that elevated or are they already on, a statin? Is their HDL low or again, are they already on a statin? And this is excluding patients with, really any degree of alcohol consumption there. Anything really more than 1 or 2 a day kind of excludes them from the MASLD diagnosis. So our primary care people, this is kind of for you when we need to start thinking about this. So really in a patient that has not been diagnosed with fatty liver in the past, but has one of these 5 risk factors, you're going to want to be mindful of that. And the primary risk assessment being the FIB-4. The FIB-4 is a calculator. You can get it on MD-Calc. It requires the patient's age, their AST, their ALT, and their platelet count. So pretty easy and basic labs that you're probably getting on your patients anyway. You can plug in those values and get a FIB-4. And the main purpose of the FIB-4 is to rule in or rule out patients that have advanced fibrosis. So once you have your FIB-4, let's say it's low, it's less than the 1.3. You can reassess again with that FIB-4 in either 1 to 2 years or 2 to 3 years, depending on whether or not they have diabetes. If the FIB-4 is high, so greater than or equal to the 1.3, then we need to do a little bit more workup there. From there, you can either do the VCTE, stands for the elastography or the fibroscan. You can get a fibroscan right off the bat, or you can get an ELF test. The Enhanced Liver Fibrosis Test is a serum test. That one's nice. You can just get it with your other lab values. The ELF gives you a predictor of advancement to cirrhosis in a certain time frame. It doesn't really give you like a fibrosis score, but more of a probability. So from there, if that's low, you can again reassess, but you're really trying to find those people that are at the intermediate or high risk. So again, if they're at that low risk, you go back up to the top, you can reassess in 1 to 2 years. If they're at that high risk or intermediate or high risk, we definitely want to be sending them to hepatology. If you don't feel comfortable getting the FibroScan or getting the ELF test, you can also refer them directly to hepatology. We are always happy to see them. All right, advanced fibrosis suspected. What do we do from there? So you're getting your secondary risk assessment with that FibroScan or the ELF. Sometimes, you do all of the things. You do the non-invasive testing, and it just doesn't really make sense. For example, you're getting that FIB4 that's really high, but then you're getting a fibroscan that is showing like F0 to 1 or the opposite. That FIB4 maybe is intermediate and their blood work looks great, their ultrasound isn't really concerning, but their fibroscan says F4. So sometimes the workup isn't always leading you to where you want to go. Sometimes you need to get that liver biopsy to really determine where exactly we are right now. And then always, if you suspect cirrhosis clinically, meaning if they have edema, if they have ascites on exam, your cirrhotics get the muscle wasting, so their arms are really skinny, the temporal wasting. If you're suspecting that clinically, or they have impaired synthetic function on lab work, you're just going to want to go right over to the right and manage the cirrhosis. But we're really trying to really fine tune exactly where they are in this stage in order to treat them appropriately. So this is a nice description for the global epidemiology. As you can see, this is affecting people globally, and it really is interesting that it's pretty even across the board, higher incidence in Latin America, but again, affecting people globally, despite their ethnicity. All right, so our natural history. So I like to always tell people that a lot of people have MASLD. A lot of people have fatty liver. It affects a lot of people because, as you know, those cardiometabolic risk factors are very common. However, only about 20%, a small subset of those patients develop a more aggressive form with inflammation and scarring. So approximately, one stage per 7 years. So you're starting, if you start at stage 1, sometimes in 7 years, you'll be at stage 2, and then another 7 years you'll be at stage 3. But that's not necessarily true. There are 20% of people that progress to cirrhosis in 10 years. So, I mean, if you really think about it with, childhood obesity, you can have someone in their 20s with moderate to advanced fibrosis. So that can be pretty scary. So this isn't just for people, in their 50s and 60s. We really have to be mindful and catching these patients early on and really modifying those risk factors to prevent them from progressing in, the 10 to 20 years. Because obviously there's high risk of morbidity and mortality when we get to the cirrhosis. In liver failure, they're at higher risk for hepatocellular carcinoma with advanced fibrosis. So really just trying to catch these patients early on and addressing things at that time. MASLD initiation and progression. So obviously, there's a big genetic component here. So I always ask my patients, like, any family history of chronic liver disease. And if they, say, yeah, my dad, my brother all passed away from cirrhosis. So you really got to, tune in there that they likely do have a genetic component that will kind of accelerate that process. It is nice that there are some genetic components here that are protective. But again, just at the initial workup, we don't know a lot of that. So we definitely need to ask the history about, the family, their personal history of obesity. Were you obese in childhood? Kind of really dig into that history to see, the predictor of, are they going to advance to, F2, F3 into cirrhosis. And this, diagram is also indicating that the gut microbiome is a big factor here as well. So some key points. So obviously, the patients with moderate to advanced fibrosis are at higher risk for liver-related events and mortality. The rates of fibrosis progression and hepatic decompensation depends on, where they are at baseline, their genetics, their environment, their underlying comorbidities. And cardiovascular disease and non-hepatic malignancies are most common in patients with MASLD that do not have advanced fibrosis. But death and liver disease predominates in patients with advanced fibrosis. Okay, so let's move into our patient presentation. This is JP. He is a 55-year-old white male with a history with a BMI of 35. He's being referred for elevated AST and ALT. He has some right upper quadrant discomfort. He's gained about 20 pounds over the past 5 years. So his AST and ALT aren't that high. I mean, they're mildly elevated. Normal alk phos and total bilirubin. Past medical history includes obesity, prediabetes, hypertension, no family history of liver disease. Rarely drinks alcohol. He works in IT, so likely a sedentary lifestyle. He's taking lisinopril. And on exam, he has central adiposity and enlarged waist circumference. But just to kind of flip here, some other etiologies of steatotic liver disease, so medications can absolutely, be the cause. So obviously just trying to, really look at their medication list, not so much to see if, could that be causing an elevation in the liver function test, but could one of those be contributing to the steatosis directly? And some other etiologies, including hepatitis C, Wilson's, hemochromatosis, HIV is a big one. And kind of less common ones being like your celiac disease, post-Whipple, meaning like you're altering that metabolism there. And some other inborn errors of metabolism and some enzyme deficiencies can be contributing to the steatosis burden. So what are we going to do next for JP? We definitely need to get some more workup. I always tell my patients we don't want to just assume this is, fatty liver. We need to rule some things out. So our initial chronic liver disease or CLD workup always will include ruling in or ruling out, viral hepatitis, the iron and ferritin panel with screening for hemochromatosis, your celiac panel, the ANA smooth muscle antibody ruling out autoimmune hepatitis, your alpha-1 antitrypsin, your HIV. Typically, the primary would be checking your lipid panel, your hemoglobin A1C, but if they're not, always worth checking. And then the PEth is, the best way I know to describe it is your hemoglobin A1C, but for alcohol. So it assesses alcohol use within the past 30 days approximately. So again, if they're not really, if you don't think they're being truthful about their alcohol use, you can always get a PEth to assess that as well. And then obviously we always want to get some further imaging to look at the appearance and the size of the liver and also the spleen. For JP, his ultrasound, the ultrasound can detect moderate to severe hepatic steatosis. This is JP's ultrasound showing increased hepatic echogenicity. The contour of the liver appears smooth. That's important. And the spleen size is within normal range. So JP has hepatic steatosis without evidence of portal hypertension. So which patients still need a liver biopsy? You do your best to work this up non-invasively, meaning, you're doing your chronic liver disease workup, you're doing your fibroscan, but sometimes you get some discordance there, or you get, positive antibody that doesn't really quite make sense with the history and the imaging. So unfortunately, sometimes you still need to get a liver biopsy to really figure out what is driving those elevated liver function tests, kind of really figure out what is the active hepatic injury. So for JP, he meets metabolic criteria. He has an elevated BMI. He has prediabetes and high blood pressure. So he meets 3 out of the 5 criteria. So for him, we would go down to the left, the yes. And are there any other causes of steatosis? He does not drink alcohol. We're assuming that his other workup was negative. So we're going to go all the way to the left and say no, and that he meets criteria for MASLD. Primary questions to answer here. Does this patient have underlying steatohepatitis? So does this patient have MASH? So that fibroscan would be important here to stage him. Is he in stage 1, 2, or 3? He doesn't have evidence of portal hypertension based on that ultrasound. So not quite, we don't believe that he's in that stage 4 category. And that will bring us to the end.